There we go. Mm-hmm. They're photobombing our meeting.
Who's photobombing?
You, I can see you in the background.
Well, I'm sorry. Is it my good side showing?
As far as I'm concerned, you're being recorded, so behave.
My brain tricks on me. Yeah.
That's funny.
Go. All right. Mwah. Mm.
Hmm.
Ah.
Good evening. You doing okay? Okay, Elaine.
There we go.
There we go. Good evening.
Evening. How you doing?
I'm all right. Just waiting for a couple more to sign up, and then we'll get started.
Okay. Sounds
You've
good.
been doing okay and staying safe with this COVID stuff.
Yeah. I mean, I work PRN at St. Joe's South at the ER, so whatever hours I can pick up there, I work.
They having you wear the PAPR, or are you wearing the regular surgical stuff?
Yeah, just the regular surgical stuff. For COVID patients that come in, we as registration can't go into the room, so they actually have phones in the room now that we call to do our side of things. That way, we don't have to use up the extra PPE.
Well, there you go. At least they found a way to keep you safe, but still function in your capacity.
Yeah, it actually makes things a little bit easier because I could just type in like possible COVID patient unable to sign, so I'm not sitting there for like 5 to 10 minutes waiting for them to put their John Hancock, which some people are weirdly picky about for some reason.
Um, Unfortunately, a lot of people who get ill, they're on a very tight budget, and so they're a little hesitant to be signing over their money.
Oh no, I meant like their actual signature. Like they will
Oh,
literally reset it because it's not perfect enough.
oh. I figure so long as it's good enough for the financial people to see it.
That's what I tell them. It doesn't have to be the prettiest signature in the world. It's just got to be yours.
Right. Which is why I almost wish, how we do the hand sign in for
Hmm.
like labs? I almost wish they would just go for fingerprint or handprint.
I mean, before this whole COVID thing was going on, they had the palm scan that patients could check
Right.
themselves in by themselves. Um, I mean, it's not that far fetched of an idea that like, you can essentially attach a signature to that, so that way when you palm scan, any documents that need to be scanned can
Right.
be automatically signed and given to you, given a copy of.
Right.
But
I'm a Trekkie, so, with the retina scan that you see in the movie, you can't, you could, you almost think you could almost scan your fingerprint from a distance and not even touch anything.
it'll get to
But
that
you
point.
never know. You never know.
I mean, the palm scanner right now, there's like about like that. Well, it's kind of hard to see on my hand, but it's like about like that much of a gap from where like the palm sits on the device versus where it
Right.
actually reads. So if we can get to where you just don't touch it, then we should be good to go for that.
Right. Well, just give it another minute and then I'll get started. Yeah, you married? You got kids?
Me, I'm just married. You know,
Okay.
been married for a little over a year now.
Well, congratulations. The honeymoon's over.
Actually, the honeymoon is postponed because
Oh,
Gina wouldn't give us time off for that.
right.
So,
I'm
uh,
sorry.
it's whatever. So we gotta wait until after the program is done, and now we gotta wait for COVID to be done too.
Right. Right. But congratulations.
Thank you.
So what'd she do for a living?
She works as a PICU nurse over at St.
Oh,
Joe's.
okay. All right. Well, it's time to start the meeting. Um, I'm going to refresh one of the concepts and move, accelerate or elevate it. Just a reminder that the lungs, they do two functions, and that makes it easy for us because the patient does the work. They ventilate, move air in and out, and they oxygenate. But one of the things I didn't cover on non-invasive ventilation last week was that whether it's on the exam or in reality in ER or ICU or even on a floor during a rapid, that if you have a bad ABG where the patient is not ventilating, you have an elevated PaCO2 and an acidotic or a trending acidotic pH, you're going to try the BiPAP first. And most of the companies in the local area, and probably even nationally, 10/5 with an FiO2 that gives you at least a 92% SpO2. The ones in reality that they try not to do, but it's kind of a double standard, is your COPD patient, the patient with the bad heart that has either congestive heart failure or pulmonary edema. But those are actually the ones in the ER that we're always doing. And in Hillsborough County at St. Joe's, Maine, and even in other counties, because I was up in Hernando County and over in Polk County with Lakeland Regional, they come in on the whisper valve, which is the equivalent of a CPAP. Okay, so for the exam, you're going to prefer a 1-to-2 ratio, but in reality, most of your patients have a disease progression to where it's a 1-to-3 or 1-to-4 even. And with end-stage COP, you can even see 1-to-5 or maybe even 1-to-6 on the IE ratio. Okay, so when you first started respiratory school in the first semester, it was change in volume equals change in pressure. So if you have a set volume, you're going to have varying pressures, and the pressures you're going to monitor usually every 4 hours, although back in the day it could be Q3 or Q4 or Q2 hours. You're looking at your PIP, And so we use the V60 now, where we just use the old Respironics smaller white CPAP BiPAP, and we had a little switch you manually change. The reason I'm bringing up the old one is MBRC sometimes when they form the test, they still rely on older nomenclatures or names. And so if you see S/T, that's spontaneous time, that means BiPAP, okay? So if it shows up on your exam, if you see S/T, you know it's BiPAP. So now we're going to talk about some of the equipment other than the V60. Usually most hospitals, you're in ICU or ER and you're using the V60 to handle the emergent situations. But now, over the last 25 years, we've seen the patient populace really increase with morbid obesity, with cardiomegaly as a disease process, on top of COPD or asthma. So you have what's called the little boxes, the ResMed, and you have AVAPs, or not AVAPs, you have APAP and VPAP. The AVAPs is on the V60, and all you do is you hit a button and hit accept, and it goes in the AVAPs. And all that is different from the other BiPAP is it will definitely deliver an assured tidal volume per breath. And that's really nice for people that you're struggling with for the consistency of the tidal volume. The other one is the other machine, the ResMed, is small, and it has APAP and VPAP. And APAP, both of these modes are usually used for nocturnal sleep apnea, obstructive sleep apnea, or you'll hear us say OSA in the field. The APAP, an assured pressure per breath, whereas VPAP is 2 levels of pressure for OSA. I'm just flipping my paper now. Okay, so on the exam or in reality, you'll follow up with an ABG, usually 30 to 60 minutes later, and what may or may not happen, depending on patient response to the BiPAP or CPAP, is that you'll still have an acidotic pH with still elevated PaCO2, and now it's time to intubate. So on the test, when you set up your vent, you're going to go to rate first. And whether it be Kettering or Lindsey Jones, they're going to recommend 8 to 12 breaths per minute. Now I made it simple for me. I just set a rate of 10, and because that's the middle of the range. Tidal volume, you have your formulas to figure out what your tidal volume is going to be. You're always going to start off with 100% because you want to make sure the brain and heart will get what you need. And the reason I say the brain and heart is the typical response in an emergency, regardless of what's causing it, injury or illness. And when I say illness, usually an acute situation on top of chronic, like a pneumonia on top of COPD, for example, or pulmonary edema on top of COPD. You still want to get that oxygen because you don't want your patient to die as a team, okay? So you give 100%, and usually if the patient responds in a positive manner, the SpO2 shoots up over 92%. And everybody gets all happy except for the RT and the doctor. And that's because we know it's the PaCO2 that affects the pH of the blood, and that's what's going to determine whether you make it or not. And then there's a PEEP of 5. But sometimes in reality, when you're in the ER, especially if you get someone with a head injury, say it's a motorcycle rider that got thrown without a helmet and they hit their head, or maybe an elderly person who's had a heart attack and you don't want to put the PEEP to squeeze on the heart, okay? So you want to make sure that in reality, you may not put PEEP 5, you might put 0. One of the times that I started off in my career, I was in the post-open heart cardiac unit over SICU over at Lakeland Regional. And a lot of times the cardiac docs wanted us to drop the PEEP to 0 because they know they just cut on that heart and they didn't want to compromise the cardiac output or drop the blood pressure any further. Even the cardiac nurses would turn to us in a time of emergency, I need you to drop the PEEP, and we would go to 0. In a ER, the classic debate is between the RTs. Well, what about atelectasis? Well, you can live with atelectasis, but you can't live without a blood pressure. If the heart is not pumping efficiently to the brain and the rest of the organs in the body, and they don't get perfused, then you're not. The likelihood of surviving the incident is low probability. All right, and then so on the test, the mode will be the last of them. So what basically happens, you have your scenario,
I have a
and
question.
you have.
Sorry. The PEEP to 0, is that for patients that are intubated or on BiPAP, or can it be for both?
I've moved on to intubated patients. I
Intubated,
apologize.
okay.
I should have
Okay.
clarified that. Yes, when you're on your test, as you go through your options, you'll have 4 answers. And Kettering's going to teach you how to do this. And the first thing you do on your 4 answers is look at your rate. Is the rate adequate to address whatever's wrong with your ABG? And then you'll look at your tidal volumes. Now, one of them will be really extreme, and so you can throw that one out. And then you look at your FiO2. Now, there is one exception to the rule when taking the exam. If you have a previous ABG and you know the FiO2 is like, say, 50%, and they have just over 100 PaO2, there are some questions where you won't go to 100, you'll go with the 50 because you have a known, PaO2 before you put them on the vent. And then, of course, a PEEP 5, and then the modes. And when you go through the modes on the exam, you'll have various options. You have SIMV, which is a weaning mode. You have assist control. You'll have a set respiratory rate and tidal volume, but the patient will initiate it. And then you'll have control mechanical ventilation. You'll see it as CMV. And you're going to get what we set per doctor's order. You might breathe over it in reality, but you're going to get a minimum minute ventilation. Okay. One of the things in reality that we have to look out for is your PIP being too high. And what you're going to hear at the seminars is barotrauma, volutrauma, and it's just where we're beating the lung to death, and the small airways and alveoli are slowly being destroyed. And so as air sac units that exchange air and oxygen, they will not perform efficiently, and they'll have to snap open. And over time, we induce ARDS, which is a stiffening of the lung and a inflammation cycle that if you don't stop the inflammation, it's a poor prognosis and outcome for the patient on mechanical ventilation or the ventilator, okay? Some of the options, when you're first setting it up, if it's an ARDS patient on your exam, you might be able to go to pressure control. So they like to throw a curveball. Later on, as the scenario progresses, if the patient's deteriorating and you have to have other options, you have APRV or you have the oscillator. I'm not sure where they're at in their testing cycle on that one. You'll get the updated information when you attend Kettering. Have you ever been to Joe's, Maine?
Once for a makeup day. That was it, unfortunately.
Okay, well, they use the Servo S and the Servo I. I'm down at Meast Dunedin, and down there we use the Puritan Bennett 840 and 980. And one of the modes that is available to Joe's Main is PRVC. And the reason that the leadership team at Joe's Main picked PRVC on the servo, this flow is variable. Every 3 minutes, the breath is measured and it adjusts the flow to meet patient demand. So they really liked it there. If you ever get an order at a different hospital, like say Advent Health, or you're down at Meast Dunedin and they want PRVC, the equivalent on Puritan Bennett would be VC plus. Okay. All right. So that takes care of that. Now, in reality, you're going to have to do some things that are different from setting up a ventilator on a paper test. One, it's electrical. You got to plug it in. If you don't have power, it runs on the battery. Most of the batteries are only 4 hours in length. Where that came into play was when we had the year with the 4 or 5 hurricanes like Charlie, Francis, Jean. So we did have to know, because if the generator didn't kick in, we had to live off of those batteries. Now, this came into play at Connerton when they had to evacuate the patients from Connerton because I think they had a fire or an electrical outage that was going to be longer than the battery life of the Puritan Bennetts they had. And they successfully transferred those patients to an acute setting until the electrical problem can be fixed. You plug in the cord, and at Joe's Main it's red, into the wall, and we do this with a blue cord at Meast Dunedin, and it says vent. You have to have a way to transmit data from the patient ventilator to your WOW, which is a computer on wheels. And so it Willy Wonkanizes the data, as I like to say, from the vent to the WOW so you can record it. The challenge here is two situations occur no matter where I've worked with a WOW. The data is usually like a minute or two late, and so it may not be accurate. And then sometimes the numbers just are off for whatever reason. Okay, so those are, and then there's one other electrical plug that you have to plug in. FDA and 6 other organizations for patient safety say that you have to have an audible and visual alarm outside the rooms. Now at St. Joe's Main, due to the 2-to-1 nursing ratio, I think they've stopped it in the main ICU. But when you go up to critical care tower 5, they have a 12-bed unit that's a step-down ICU or an overflow ICU. Up there, we still plug them in. And that one's not just an audible alarm to the point where it just beeps. That one says vent alarm, vent alarm. It's an actual human voice, which gets kind of interesting after a while. You have 2 compressed gases, the green hose and yellow hose, of course, oxygen and air. And then, sorry. Before the WOW will accept the data, on the Cerner software program, and I'm sure on Epic at TGH or whatever program is instituted at the hospital you work at, you have to have a way to associate the ventilator to the patient you're taking care of in that room before that data will come over. It's just not a click of the button and it happens. You have to, back in the day when computers first started, you had garbage in and garbage out. Well, basically, you have to tell a computer what you want it to do for it to be efficient in its task. So there's a little icon on the Cerner that has a monitor and the head of a person, and you click on it and you say associate. And no matter where you work or what company you work for in the Bay Area, when you go to associate, you have to type in the number that's assigned to that ventilator. And then once you do that, it allows you hit accept, and then it allows the data to flow. And then one of the situations that usually happens is people get in a hurry to be productive when they go to extubate these patients, and they don't disassociate. So when you go to associate, You have to disassociate from the previous patient so you can associate, and it's just a time management situation. All right. When you go to your Lindsay Jones, there's a weaning section on the ventilators. And there's a couple different ways that you can wean on the test and in reality out in the field. You can do a stop cold extubation. Now, there's two situations this normally occurs. One is in reality, when you have young people who have mixed drugs and alcohol and OD'd, they wake up and they're strong, and it's not natural to have the tube down between their vocal cords. So they just want to rip it out. Okay. Anybody with me? It looks like I might have lost you.
I'm still here.
That's okay. I'm trying.
I'm here.
Okay.
Me either.
All righty.
Sorry.
No, it's okay. Can you folks still see and hear me?
Yeah.
Okay, I'll just, there you are. Hey, good evening. Anyway, the OD, the doc will come by, either Dr. Katz or Dr. Sierra will say, pull the tube. And you'll go, are you sure? And they'll go, yes. And they'll just keep walking. They know that they're young, that they didn't really primarily have a lung situation. I'm sorry about that. That's my cat. That's Miss Marilyn. Sorry about that.
Where is she?
But anyways, then we pull the tube, put them on nasal cannula, and they do fine. The other stop cold reality in your career will be the CMO. And what will happen is two doctors will determine that the patient is not viable or will not have a qualitative life. And so once they both sign the order, it's usually a palliative care doc that'll put the orders in. And always double check your order, even on a CMO. And you'll end up waiting for the family. Sometimes the chaplain comes in, says a prayer with the patient. Or if people are of other cultures and other faiths, their representative will come in and do whatever is appropriate per their faith. And you'll pull the tube. And usually those orders in Baycare, I know, is 2-liter nasal cannula. But when you're somebody like me who works in an LTAC, a long-term facility, is trach peg city, we'll go to a 28% trach collar. One of the ways that you may do a open heart patient, for example, is different. You'll use SIMV. When they first come out at Joe's Main, we usually get a fax from anesthesia. You'll have an SIMV rate of 10 to 12, 50 to 60%, an appropriate tidal volume, and then 5 a peak. And then when they first come out, you'll do ABGs to make sure the acid-base balance is within normal parameters. And you'll also have the nurse pull from the PA distal port of the Swan-Ganz. And what it is, they track the mixed venous from the heart at the pulmonary artery, and they calibrate their monitor, and then they track it from there. And I believe the standard's like 60 or 70%. And it's kind of like a before and after situation where you're putting in 60%, you want to be able to get so much through the heart to sustain life. And then the cardiac nurse will do her pumps, which is usually a bunch of vasopressors and some pain med, and they'll make sure the patient's stable. And then you'll always wean the FiO2 first, get it down to 50 or 40, and then you'll start weaning the rate back to where the machine does more and the patient does less. And when they wake up, you're usually on CPAP, and that's in Baycare, but for Advent Health, they'll use the word pressure support ventilation. You're usually 40%, 10 of pressure support, and 5 of peak. And then you'll get ABGs, and then you'll do your parameters. The book says that for tidal volume, it has to be greater than 5 mils per kilogram. The VC is greater than 10 mils per kilogram. I like to say 1,000 on the VC or double the tidal volume. The NIF/MIP, most people in the Bay Area say NIF, greater than -20. And then RISB less than 105. And the formula, of course, is respiratory rate divided by tidal volume expressed in liters. And the whole key, and you're going to get this in Kettering, they're going to say know your units, and when in doubt, know your units. Okay, but it all starts first with the ABG. It does not make sense to extubate a patient on life support before the ABG has been corrected. Okay, for you, 8 out of 10 times, it's probably a elevation of PaCO2, making the pH acidotic, and we blow off, as we say in the field, the PaCO2 until the pH normalizes. How do you know you have someone with the disease of COPD on a vent? Well, if you have an acidotic pH and an elevated PaCO2 and they have an elevated bicarb, ding, 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 ding. The elevated bicarb is your key to knowing that they have COPD. But one of the things Kettering will teach you, and I always reiterate to my students, know your history. When you're taking the ClinSim, you get to pick some variables on the computer screen before you start your test. Make sure you pick your history. If you get in the middle of a scenario on the ClinSim and someone starts to go bad and you know you have to intubate, if you don't have their height or their weight, you can't calculate their tidal volume, okay? But what's nice about the computers is you can go back and look up the history, okay? And it's nice to know if they're a COPDer or someone who smoked for 40 years, which we call no lung or an anaerobe in the biz, as we say, to know that you've got to have a certain PaCO2. Can somebody have a good pH with an elevated PaCO2 at 55 to 65? In reality, yes. Their bodies compensate through the years with the brain breathing a little bit more. So in reality, a respiratory rate of 26 to 28 may be their norm, but their kidneys will buffer it with the bicarb, sodium bicarb, okay? Some of the other things I look at as a seasoned respiratory therapist when I go to extubate, do they have a level of consciousness? And I call it LOC. And where this comes into play, the type of patient is after surgery. They've been given all kinds of medicine by anesthesia to knock them out so they can cut on their chest for open heart, tear the knee apart to reconstruct it, put rods down people's spines. You do not want to be awake and in pain during that procedure, okay? So they really knock them out. So you're waiting for them to wake up, okay? But when they do wake up, squeeze my hands. You want to make sure that they can follow instruction. Lift your head up off the pillow by putting your chin to your chest. If they can follow directions, then you know that they'll be able to do the test that you need to do, like the NIF. You occlude the airway with an adapter. Forgive the expression, please suck air in on the straw. It's like taking a drink on a chocolate shake, okay? Or the VC. Blow, 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 till you can't blow no more. You're blowing out a candle at the foot of the bed through the straw. Only in this case, the straw is the endotracheal tube. You want to make sure they can cough. One of the things that I do is if they can cough the sputum up through the ET tube and even into the accordion on the way to the HME, I let my doc know they got a good cough. If they cough real strong and nothing's coming up, I report that too. When I started 26 years ago as a respiratory therapist, a cough was one of the things we assessed. These days, it's not always asked about, okay? Check the pulse. Okay, Elaine, you need to come put her in our room. Sorry. In a cardiac unit such as CSU at Joe's Main,
She just loves her daddy.
I know. You want to turn to the nurse. Are they hemodynamically stable? Do we have a good blood pressure? Is the pulse good? You don't want them tachycardic at 150 before you extubate. And you don't want them bradycardic at 30 either, though. It goes both ways. And then you want to normalize PaCO2 if that's their history on your ABGs. You can't always go by the ETCO2 because ETCO2 is a variable that can be changed. Okay, any questions so far?
No.
Okay. Okay, one of the concepts I go over is we trend data with our Q4 vent checks. And one of the sections you want to look at, it's in the patient monitored parameters or patient response, is the PEP and the plateau. And what you want to do, PEP is peak inspiratory pressure. It's the max pressure between the outside of the lung and the inside of the chest wall. We've already discussed not over distending the lung tissue, especially at the ovulus and the small airways. Plateau, that's a maneuver where you do an inspiratory hold and you want it less than 30, and it eliminates the machine, 6 feet of tubing, and your airway, whether it be an endotracheal tube or a tracheotomy, to where you're isolating the pressure, stabilizing the gas exchange out to just the small airway and ovuli, which is what your doctor wants to know. What is the patient doing? Not the machine, but the patient. And so if your PIP goes up and your plateau stays the same, you have increased airway resistance. And so the treatment to that on your exam would be suction and bronchodilation, or what you know is as a duo-neb nebulizer. Although with COVID-19, some of the hospital systems, not necessarily here in the Bay Area, have gone to individual MDIs to eliminate. My wife's just reminded me that they've already done that at Brooksville. It eliminates secondhand aerosolization to protect the healthcare practitioners in the room. The other situation, PIP goes up and plateau goes up, you have decreased compliance. And so you can use adult respiratory distress syndrome as an example of that happening. What happens typically in ARDS, your PIP will go up, you'll have refractory hypoxemia, regardless of a high level of oxygen. And so the treatment for that would be to increase PEEP and treat the original symptom. What caused the ARDS? Now, over 15, 20 years ago, Central Florida experienced a really bad pneumonia. People in their 20s were on vents and they went in ARDS. We had some 20-year-olds that didn't even survive 7 days on a ventilator. When the H1N1 came through, I had a young lady, she was late 20s, early 30s. She had 2 children and a husband. She did not survive the H1N1. And it was the same thing. She went in the ARDS. So we do the alternative therapies if they're available, the oscillator, APRV. We actually did a study at Lakeland Regional where a young man had a family. He got in a really bad accident in MVA, and we did what's called partial liquid ventilation survey. We were one of 5 hospitals worldwide to do this research. And what it was, if you ever saw the movie The Abyss, the deep sea diver has his whole helmet and suit filled with liquid oxygen. And it's called poflubaron. And we actually filled the lungs to a certain point with this fluid, which is liquid oxygen. And what would happen is the debris, as the lungs were healing, would float to the top. So we had an intensivist, Dr. Sandifer headed up the project, and he and his partners would come down and do emergent bronchs to get rid of the excess debris. And he was one of the first ones to actually live through this experience with the partial liquid ventilation. So we went through every day, got x-rays. to make sure the fluid was at the appropriate level. And we did a checklist, and the checklist was the PaO2 divided by FiO2 ratio. We also did the x-rays, all 4 quadrants. Now on your exam, when someone's in ARDS, you'll know the key words ground glass appearance or butterfly appearance. You want to keep an eye out for that. An example of that would be, you have a 20-year-old MVA patient that had a tib-fib fracture. They're in post-op. You put them on the vent. When the appropriate time occurs, you'll have them on CPAP 40, 10, and 5. The young man who was a motorcycle driver, rider, wakes up, and he's all over the bed. You have good ABGs. You have borderline NIF and VC. What do? Well, in this case, you extubate him. If it takes 4 people to hold him down, he can breathe. But they might,
Spelling of that if you need it.
they may do a twist on it. All of a sudden, the SpO2 drops, the patient's diaphoretic, they're breathing 42 a minute, their heart rate's 150 a minute, and x-ray shows up and does an x-ray, and you have ground glass appearance or butterfly pattern on the x-ray. You don't extubate them. You would put them back on a rate and rest them, probably CMV, because the x-ray is the key to that one, to where you have to support the body till it heals up. So they'll do different scenarios with different little twists. And what you'll learn when the time comes with Kettering, or even through Lindsey Jones, there are key phrases on the test to help you see your patient so that you can better treat them. The whole point of the test is to make sure that you know what you're doing and that you're delivering safe care to your patient. When the PIP goes up and you have the ventilator actually in front of you, one of the ways you know dissection is the waveform will get a little wavy. It'll get rough. Normally it goes up, straight across, and back down. Inspiration, you plateau it off, and then they exhale. Then you have a little dip. That's where the diaphragm triggers the next breath. But you'll notice suction when it's wavy. Okay? All right. So barotrauma, volutrauma, it's where we overdistend the small airway and ovuli. What happens in ARDS or even with COPD, the ovuli will have to snap open and close. And so every breath can cause an inflammation state. We already talked about the signs and symptoms, refractory hypoxemia and high FiO2s. The diagnosis we kind of hinted at, the PaO2 divided by FiO2 ratio. Now I learned it a little easier than the way you're going to have to. Back in the day, even as late as 2012, less than 300 to that formula was what they called acute lung injury. Less than 200, it was full-blown ARDS. And when you go to do your weaning on Cerner through the Baycare system, we have a weaning section, and you have different qualifiers. The first one will be the pH. Is the pH greater than 7.3? Do you have a PaO2 divided by FiO2 ratio greater than 150? You don't want to take that into your exam because it's going to have to be over 200, okay? Is the hemoglobin 7.0 or greater? I had a patient this week. She had a 6.5. No, he had a 6.5. And so I couldn't put him on his CPAP trials because they had to administer some blood work, some blood units to him. So that day he got to rest. Let's see. Vasopressors. If you're on more than 2 vasopressors, like the open heart patient we discussed, you're not going to wean that patient, okay? You have to be able to survive off the machine without the vasopressors. There's a few other quantifiers. Some things that'll disqualify you in Bay Care. Do you have the ICP in? Are you on APRV? APRV is somebody that you're not going to do a CPAP trial until they time out on as the lung heals. Are you on an oscillator? You won't be weaning that patient. Those are some of the disqualifiers on that list. And where I work at Meast Dunedin, it's a long-term trach facility, but we have to go through this list before we ever even try CPAP. We have to justify per protocol that the patient is ready to wean, and we just fill this out every morning. At Joe's Main, it's filled out by night shift, usually around 4 or 5 o'clock. And at Joe's Main, they do bed to bed report, and they have a form, SBT, spontaneous breathing trial, pass or fail. If they fail, you don't even try. If they pass, then you get with the nurse, because your success as a respiratory therapist in assisting the patient and succeeding in a weaning trial depends on how good of a communicator you are with your nurse. You have to have the paralytic off. You have to have sedation off. Our protocol at Meast Dunedin LTAC, Lyant Hospital, no propofol at all for the CPAP trials. And you can only achieve that if you discuss it with your nurse. Okay? All right. We've discussed all that. Okay. What if you're going to intubate? You're going to need an ambu and mask. Make sure it's to the green flow meter. Now, that sounds ridiculous to you because you've learned to do that because green is oxygen. But you're going to find nurses that are going to need to be trained because they don't get that much training in respiratory. And so I teach green for go. I've seen in more than one county, more than one hospital where the ambu bag was connected to compressed air. It gets really confusing for them because now they have an adapter that goes both to oxygen and air that's clear. So don't be surprised if you see someone whose adrenaline's pumping and they're in the hurry that they hook it up to the wrong one. And you want it flushed to 15 liters. I like to say I like to hear it from the doorway. You need suctioning. I've intubated in more than one county, and you can't hit your target if you can't see it. And some of these people have a GI bleed, or they were going to aspirate, and you have foreign material food. You have blood, you have sputum. It can all block the airway and the view. Fortunately for you, I can't think of it right now. I'm having a brain fart. I'm sorry. It's the one with the handle that allows you with the camera to see. You can see your airway a lot better. I'm old school. I still use a Mac.
Bronchoscope? What
The
you're talking about?
Glytoscope? Yeah.
Glytoscope. Thank you.
Glytoscope.
That's the word I was looking for. But they even have the handheld King scopes now too. I prefer the Glytoscope. The only problem I've ever had with the Glytoscope is sometimes the tip will get covered with material or it'll fog up. But I'm getting better at it. If you're assisting a doctor and they want a Mac, you can remember it's kind of curved. Mac has a C in it, whereas the other one looks like an L. Miller has a double L. Okay. You always ask what size tube the doc wants. Now for Kettering or MBRC, they say males tube 8 to 9. Well, which one do you normally see? Most males get an 8. And then for the ladies, 7 to 8. Now in reality, we try the 8 first. Okay, but don't be surprised when you take your ClinSims that they want a 7 for the lady. Okay, the mark that they use as the standard is 21 to 25, and that's for oral, and that's at the lip. Okay, 21 to 25, but nasal will be 26 to 29, and it's because you have that extra space within the cranium to make up the difference, and that's why it's deeper. So 21 to 25 If it's at the lip, orally. If it's nasally, 26 to 29. Confirmation, one of the easiest ways to confirm your patient's intubated when you do intubation is chest rise, and you're listening for bilateral breath sounds and negative stomach sounds. If you hear air moving in the stomach, you're in the wrong orifice, okay? EtCO2, back in the day, we had the color, it went from purple to yellow. And the way that worked is the sensible water loss per the breath when you bag would activate the pH of the paper, it's litmus paper, and it would change color. You have to beware though, if you see a lunch there and there's a soda that's half drank, the patient had half that drink, it's possible that the gas from the soda can falsely activate that paper. It's rare, but it does happen. These days, though, you're fortunate. You have the number on a little monitor that it can attach. At Joe's Main, they use what's called the EMMA, and we use it for CPR. And during CPR, if you have a CO2 less than 10, you don't have good enough perfusion during manual CPR, someone going on the chest. Now, one of the other advantages to St. Joe's Main that I don't have at Meast Dunedin Alliant Hospital, they have the Lucas, and that's the pneumatic piston that when they hit it on, if it's placed properly, will do CPR and you won't hurt your back, okay? Chest x-rays, the difference between the start of my career that you have is when they get a chest x-ray today, it's right there. You can look to see if your tube's properly placed. Well, what is proper placement for an EtCO2? It's below the clavicles, but 2 centimeters above the coronite. Now, when I used to have films, I used the tip of my finger, the first notch, and that would be proper placement. Some people say this between the second and third intercostal at the cardiac notch. The main thing is when you intubate, SpO2 greater than 92, hopefully it's 100. You got a good rate going, 12 breaths a minute, 10 to 12 breaths a minute, and that you have bilateral breath sounds with negative stomach sounds. And hopefully your EtCO2 is at a rate, or excuse me, an EtCO2 between 35 and 45. But keep in mind, know your history. Does anybody know if they were a smoker? They may be 45 to 55. Now, one of the things on the x-ray you can tell COPD is hyperinflated lungs. Is the area between the ribs wide? Are the lungs long? Long lungs with wide spread between the bottom of one rib and the top of the other, that's COPD. Sometimes when you're bagging, you'll hear a sound when you go to squeeze. You're not giving the patient enough time to exhale. That's your I to E ratio. And you always follow up with an ABG. And the reason I mentioned the clavicles, if you don't have your tube down far enough, what'll happen, sometimes in the back, it'll curl and it'll come up. And you'll have a leak, and then you'll add 2 cc's to it. And then the next shift will have a leak, maybe 2, and they'll add 2 cc's. And what happens is, right here, these are the vocal cords, and the tip will sit just at the vocal cords with the balloon occluding the space between the vocal cords, when what you really need to do when they're totally sedated so they don't bite you is you deflate the balloon and you shove the tube deeper and then immediately reinflate. You oral suction before you do that so you don't give them an aspiration pneumonia. But if a tube's in there so many days, it'll curl in the back from the temperature of the body in the oral pharynx. And so where you think they are is not where where the tube's not actually at, okay? I've seen an open heart patient bite clean through a tube to where you could put the pinky in the hole of the tube. One of the scenarios you might come across, a patient's not ready for extubation per clinical presentation, but they have a blown cuff. What do? You just reintubate that patient. Then, when the patient in reality in your ICUs or your step down unit, they get to the point where it's 10 to 14 days later, they do the tracheotomy. Um, some places do perk trachs. We were doing perk trachs at Lakeland Regional before I left there in 2000, and that's done at bedside. At Town and Country, when they had a respiratory department, I helped with a perk trach, but the surgeon would have the pulmonologist actually have a bronchoscope down to watch in the suction as the procedure was formed. So it depends being performed. So it depends on who's doing it as to the style. So each hospital and each staff of doctors will have their preferred way of doing it. Okay. We're coming up on the near the end of this presentation. Are there any questions?
No.
Not at the moment.
Not at the moment.
No.
Okay. Is there anything you'd like to hear or see next time?
Mm,
Well, this is just my personal thing, but medications has always been my weakest point throughout this entire thing. So
Okay.
any info you have to illuminate on that would be amazing.
How about this? Next Monday, I'll go over pharmacology.
Good.
That
very
would-
good.
good.
Yes.
That'll be good?
Yeah.
Okay. Well, I'm an old 60s guy. Tune in to the same RT station at the same time next Monday, and we'll have a pharmacology presentation.
Sounds
Very
good.
Okay?
Donnie,
Oh, you're welcome.
thank
You folks
you.
take care.
See you next
All right.
Monday.
I'll see you
Good night.
next Monday.
Bye.
Good night.
Good night. Take care.
You too.
Bye-bye.
Bye-bye.
No, she's fine. Actually, one of them got a kick out of it. It's okay.
I've been reading about weird things happening with animals.
That's okay.
At least you didn't get weird on you.
All right.
Blondie won.